Clinical trials are the backbone of how advancements are made in medical care. In fact, I would say myeloma is the poster child of that because in the recent years, in the past 2 to 3 years, some very large international randomized clinical trials have come out that have changed the paradigm of managing myeloma completely. Now we're using CAR T-cell therapy earlier. We have T-cell engagers or bispecific antibodies, etc. While clinical trials are so important, we also know that the accrual to clinical trials has been very disparate. African Americans and Hispanics tend to be severely underrepresented in clinical trials in the US. There are several reasons associated with it. When we were talking about clinical presentation of myeloma, we discussed that African Americans can have more kidney dysfunction, more anemia, more calcium problems when it comes to presentation for myeloma. And even while on treatment, African Americans are more likely to get kidney dysfunction or be on dialysis or have more anemia or calcium problems. Well, the implication is our clinical trials have strict inclusion criteria. If a patient has lab abnormalities or other comorbidities that are excluding them or making them not meet the inclusion criteria, that patient's not going to be able to go on the clinical trial. And this has been perpetuated time and time again. Inclusion criteria are one factor. We also know that typically our clinical trials can be extremely demanding and are almost like written in stone, that there are very strict criteria when a patient has to be on a clinical trial, and the patient must follow all those visits, all those labs and bone marrow biopsies and imaging and correlative studies, etc. So if you think about it, patients who are uninsured, underinsured, lack of a very strong social support system, have an utmost need to maintain their employment and cannot afford to take time off. A lot of these socio-demographic factors, which tend to be much more prominent in African Americans and Hispanics in our society, well, those are the patients who are more likely to not opt for a clinical trial. So it's almost like a double whammy. On the one hand, we have clinical trials that are not suited for patients who have more disease burden, need more urgent treatment. And at the same time, there is this web of socio-demographic economic factors that must come together to get the patient enrolled into a clinical trial. And unfortunately, those factors do not come together so efficiently in African Americans and Hispanics. So with that situation, our African American and Hispanic patients are less likely to be enrolled on a clinical trial, which means that when the results become available, those results may not be fully applicable to the racial ethnic minority groups that we have, which are underrepresented, and they are traditionally underrepresented. And unfortunately, that underrepresentation becomes perpetual. I should add there, though, that the situation is turning around slowly and gradually. African Americans historically, so African Americans make up about close to 20% of myeloma patients in the US. Historically, their enrollment in clinical trials that have led to FDA-approved drugs, including ones in myeloma, their enrollment historically has been less than 5%. So a demographic that makes about 20% of the population and is less than 5% seen in clinical trials. But more recently, this disparity is being bridged somewhat. So now clinical trials are making a lot of efforts. Inclusion criteria are being modified. I'll give you a small example of this. There is something called the Duffy antigen status. We know that African Americans are more likely to have what's called neutropenia or low white blood cells, which is completely benign. It doesn't have any clinical implications. And in fact, historically, it used to be called benign ethnic neutropenia. But because of neutrophils being low, African Americans may be less likely to get enrolled on clinical trials. This Duffy antigen status, or benign ethnic neutropenia associated exclusion from trials, is being identified, and appropriate language is being put into the clinical trials so that African Americans can be enrolled despite that Duffy antigen null status. So this is one example, but clinical trial criteria are being modified and slightly more relaxed. Now, I would say real world clinical trial inclusion criteria are being tested in some of large prospective clinical trials, hopefully with an effort that they would make the trial more convenient, user-friendly, and more likely for the traditionally underrepresented groups to be enrolled on the trials. Similarly, some social kind of strengthening of the social infrastructure for underrepresented patients is being set up. For example, providing them with transportation to come back and forth, providing social worker support to institutions or clinical trials, etc. Clinical trials are being held responsible for these numbers, so it is no longer just a projection that, okay, we'll enroll 15% African Americans or something. Regulatory authorities are looking at this much, much more in detail. And in fact, sites that are more likely to enroll African Americans and Hispanics are being encouraged to join the trials. So while historically there have been perpetual disparities, I think the pendulum is swinging a little bit, and it is actually bringing us closer to where we have a more desirable clinical trial structure and a more appropriate patient enrollment, such that our trials are not drug-centric, but they are more patient-centric and can enroll a population that is more represented or representative of our US demographic when it comes to racial ethnic minorities, and I would even say when it comes to gender, etc.